Thank you, Bert, for that kind introduction. People who know me know it's like the worst thing for someone to bring that kind of attention to me, so feeling a little awkward, but okay, so here we go. So advancing population mental health, why is it important to know what works? Thank you so much all for coming here today. It's great to see such a large turnout, and also online I know there's a great turnout, and my goal today is to get you all really excited about my passion, which is population mental health. And I hope you'll feel inspired and think about it a little differently today at the end of the day. And also, I know there's a lot of students and trainees here, so I really hope we'll help you feel excited about making mental health the focus of your careers. So we're all familiar with the headlines in the US and elsewhere saying that we're having a mental health crisis. And headlines are designed to grab our attention, and they do. But this symposium aims to go behind the headlines to really tell us what the data say about population mental health and move towards actionable solutions. Okay, this isn't working. All right, sorry, that's not working. So what do we know about population mental health? So we know that mental disorders are common, and we've known this for at least 40 years now. In the US, we know that 1 in 4 US adults lives with a mental illness, and 1 in 20 adults lives with a serious mental illness. And a serious mental illness is a term you may hear again today. And what that means is you have a mental health condition that interferes with one or more areas of functioning in your life, like going to school, being employed, having a stable relationship, or managing money, and usually refers to things like major depression, bipolar disorder, schizophrenia, PTSD, and OCD. The most common disorders in the US are anxiety disorders, depression, post-traumatic stress disorder, and mental health conditions affect all races and ethnicities, with the highest prevalences in the last 12 months among adults who report being multi or mixed race and in LGBTQ communities. So those were 12-month prevalences, but it's really striking when we start looking at lifetime prevalences, because the proportion, of course, is much higher. So these are examples from a number of different cohorts. And one, if you look at the first one in green, it's the Danish registry data, and that's population registry data from Denmark. And you can see that there 30 to 40% of adults have been diagnosed with a mental illness. National Comorbidity Survey, which is Ron Kessler's population-based data in the US, you get to 40 to 50%. But what's really striking is when you start looking at prospective cohorts, so those are cohorts where they follow people over time, and they repeatedly assess them for mental disorders. And there, when you get to something like the Christchurch or Dunedin study, in adulthood, 80% of those cohorts have had a mental health disorder diagnosis at least one time point. And what does that tell us? That tells us that the majority of people will suffer from a mental disorder at some point in their life. It may only be one time in a specific circumstance, but it affects the majority of people. The other thing we know is that mental disorders onset early in life, unlike other chronic diseases like cardiovascular disease or cancer. And you can see that here. I don't know if this is working. Is this working? Yeah. You can see that here with the cumulative incidence curves, and you can see that there's a rapid onset of mental disorders in youth and adolescents, with the median age of onset around 18 for both males and females. And then there continues to be onset, but it's much less rapid over the rest of life. And why is that important? Well, it's important because mental disorders affect all aspects of life because they affect cognition and behavior. So having a mental disorder makes it less likely that you can finish school, graduate from high school, finish college, engage in a stable relationship, or manage money. So having a mental disorder early in life can have this ripple effect, affecting all aspects of one's life through adulthood. There's also some evidence that the prevalence of mental disorders is increasing, and especially among youth. So this map just shows the share of the population with mental disorders. This was 2006, and basically the darker color, bigger part of the population, up to about 20%, suffers from any mental disorder. Then if you look in 2021, you can see that, this didn't move. 2021, you can see that more of the areas are darker, and that's true globally. And then when we talk about mental illness rising faster among 18 to 25-year-olds, this has been debated, but these are from diagnoses, from diagnostic data from SAMHSA, and you can see that in 2008, 19% of young adults had a mental disorder, and in 2018, it was up to 26.3%. I've seen some data recently that suggests this may be leveling off, but it's always hard to compare given changes in study designs. And people often ask what happened during the pandemic, and there is some evidence that some of these numbers are worse among young adults and youth in following the pandemic. The other thing that people sometimes aren't aware about mental disorders is that they increase risk of chronic disease and early mortality. So we think of mental health as the foundation for physical health, and people with mental health problems are at higher risk of major chronic diseases like cardiovascular disease, diabetes, and cancer. And if they get cancer, they're less likely to be treated for it. And if they're treated for it, they're less likely to have a good outcome. Mental disorders also predict early death, and you can see this, it's true. So some people think, oh, that's due to accidents or suicide, but actually predicts earlier death both to natural causes and external causes like accidents, suicides, being victimized. And you can see that the mortality rate ratio peaks around 33 years of age, but it stays high even into older age. Despite all of this, there is a significant mental health treatment gap. So I'll show you a couple examples of this, but these are data from the WHO World Mental Health Survey, and these are adults who are diagnosed with PTSD. So they met all the criteria for a diagnosis of PTSD. And you can see that even in high-income countries, less than 30% were receiving any specialty mental health treatment. And in low-income countries, it was less than 5%. If we look at the US, we can see that less than 50% of those with any mental illness are receiving services, and it's a little better for people with serious mental illness, but still 30% of adults with serious mental illness aren't receiving services. So what can be done to advance population mental health? Well, that's one of the things we're going to talk about today, but here's some thoughts. So one, we can address the level of need. In the US, we have low workforce capacity to treat mental health relative to some of our high-income peers, and there are steps we can do to improve access and supply of treatment. For example, we need to address the shortage of mental health providers. We also need to develop new treatments. The observation on this slide was made by Steve Hyman, who is former director of the National Institutes of Mental Health, and it still mostly holds true, with the exception perhaps of ketamine and some of the psychedelics. Our medications for psychiatric disorders are really stuck back in some of the mechanisms that were discovered in the 1960s. That said, at the same time, consumption of antidepressants has massively increased globally in the last 20 years, and this is just some data from Europe on this. And so, of course, we have to increase access and improve treatments. However, it's also been noted, although there's lots of debate about what this means, that especially during the pandemic, more of the population was accessing mental health treatment, but less of the population reports excellent mental health over time. So what's going on? To me, this suggests that other measures may be necessary to address the scope of the problem. So normally when I hear people talk about the mental health crisis, they focus on increasing access to treatment, which is really important, and improving treatments, because we do need better treatments. Those are two things I work on myself, and they're really important areas. But if we really believe the epidemiologic data on the scope of the problem, which is something we've known at least since the 1980s, and if we believe that this may be rising among youth, then only using a traditional medical model of treatment, which is two people talking in an office or a psychiatrist giving a person medication, it seems at best limited. So in my view, we need population-based solutions. And to frame this discussion, I'm briefly going to talk about a couple of success stories where a big public health problem was addressed and progress made. And these are more to provoke people to think about, I don't have the answers on what this should be, but to start people thinking about it. So if you think about motor vehicle-related deaths, for a while now, for ages, we've known that even though the numbers of miles people drive goes up, the number of motor vehicle-related deaths have decreased. And did we do this by getting each individual an individual driving coach? No. We did these by many different legislative interventions, such as cracking down on drunk driving, changing speed limits, raising the age for teen drivers, making it more attractive to have a safer car, and setting regulations around car safety and seatbelt laws. I can remember when I was a kid, no one wore a seatbelt. And now my kid puts it on as soon as he gets in the car. And there's similar data from other countries. So these are data from Germany showing that legal amendments, which are the red dots, were associated with less death in road traffic accidents. And although smoking remains a major public health issue, particularly in specific demographic groups, overall smoking has dropped massively in the last decades. And when we think about what's responsible, we didn't get each smoker a smoking cessation coach, although smoking cessation coaching and interventions can be very effective. There were many public health measures done. So we need to think about mental health in the same way, focusing on population health and prevention. And the challenge is we continue to be trapped in a very old school model of treatment where an individual treats an individual in an office. And it's not that some people don't need that. It's not that medication doesn't help and individual therapy can help, but we need to expand our ideas of what interventions might be. And some of the speakers today will talk about that. So one example I'll give here, which we won't discuss in the other talks, is economic stress. So there's a ton of evidence that economic stress is related to worse mental health. This is just one example. We could do a whole day on this, but these data show that adults with fewer assets, whether it's income, savings, or education, have more depression. So a question is, does reducing economic stress or increasing assets, improve mental health? And there is some evidence that it does. For example, work by my colleague here, Rita Hamad, who's an associate professor in social behavioral sciences, has shown by a natural experiment how changes in economic policy may improve or shift the curve in mental health. One of her studies showed that when Congress expanded the child tax credit during the COVID-19 pandemic, the increased income for low-income families improved parents' mental health, less depression and anxiety, even though it didn't change treatment use. So we might start considering economic policy as a lever that can improve or actually harm mental health. So I'll just end with why we need data, and maybe this is probably not a crowding to say this for, but we need data in the right study designs because it's important to provide evidence for what works and what does not. And I'm going to close with a cautionary tale on why. So I was living in New York City. I was a postdoc at Columbia during the 9/11 terrorist attacks. I saw the second plane hit the tower when I was in my office where I was meeting with Sharon Schwartz, who's someone many of you may know. And although I'm a professor of epidemiology here at Harvard, I am a first licensed clinical psychologist who specializes in treating trauma and PTSD. And I had done my clinical internship in New York City. So the day after 9/11, my internship director called me and asked me to help her because she had been asked to go support families who lost people in the towers. So in the end, about 2,700 people died in the attacks. And so I joined her, and I was on call for families were flying in because people at one point we thought people were missing. They didn't know where their loved one was or if they were dead. And so families were flying in from all over the world. They met people from Sweden, different countries, and I would just be on call. So if they wanted to talk to someone, they would sign up, and I would just listen to them, provide support, also help with logistics because they didn't know where to stay, that kind of thing. And then over time, it became clear that the people missing were dead. They weren't going to be found. So at that point, we started giving family members opportunities to go to ground zero and talk to the firefighters and the engineers, and sometimes do ceremonies to have some closure and to accept that their loved one was gone, because most of them didn't get any bodies for years and years and years later. So that's what I was doing. At the same time, many mental health professionals rushed to New York City because they wanted to help. And that's understandable, because when trauma happens, people want to do something. It's very hard to sit with the helplessness. So mental health professionals flooded New York City, and they wanted to help people who'd been directly affected, who'd escaped from the World Trade Center. And you can see here there was like 16 or 17,000 people working. So there was a lot of people affected. And some of this was employers had people, wanted to do things for their people who'd been in the tower. So what they offered at the time was something called critical incident stress debriefing. So this was a standard of care at the time. It's what FEMA did. It's what the Red Cross did. It was best practice. And basically what it involved is sitting with an individual, either individually or sometimes they did it in a group, and the person was supposed to talk in detail about the trauma they experienced. And it was done acutely after an event. So this was like literally within weeks of what happened. And it was all done with the best of intentions. Many employers mandated that their employees go. And again, everyone wanted to help. That's why it was done. So when the chips all fell and people looked at whether this was effective or not, and they studied it, they found that at best, this intervention was neutral, and at worst, it actually caused PTSD in people. And I had a friend who experienced this personally. She called me. She had gotten out of the towers, and she was distressed, but she was okay. She had some distress for a week, but she was getting better over time. Then she got a call to show up for a CISD group, and it was mandated by her employer. So they had people sit in a group, and they each had to talk in detail about what they experienced. That night, my friend who had been feeling better started having nightmares, not just about her trauma, but about the other traumas in the group. It's a contagion effect that can happen if you do these groups too soon after an event. And she developed PTSD, not from the attack, but by the well-wishers who wanted to do something to help her after the attack. So I learned very early in my career that common sense wisdom, what is even best practice, which seems like a good idea at the time, can actually be harmful, and that sometimes doing something is not necessarily better than doing nothing. And so just to say, there was a review of debriefing in 2002, a little late, which said there was no evidence to support it and said it should cease. So with that, I'll go to the question of the day, which is how can we apply our understanding of mental health into actionable interventions that benefit entire communities? And we'll be addressing this question, or getting a start on it anyway, with our great speakers that are going to be talking about methodological challenges for common mental disorders. And then just to take you through the day, and then we will have lunch. And for all the people in person, I'm sorry for those online, we couldn't send you lunch, but all of you in person will have lunch provided. And then in the afternoon, Dr. Andrea Denise will talk about causal inference and population mental health. Why should practitioners care? Then we're going to have a panel discussion, and I'll have some questions, but we're going to take questions from the audience and online. So we welcome your questions, and then I'll make some closing comments. And then at the end, we have a reception in the cafeteria. So even if you have to leave during the day, please come back for the reception, because I can promise you socializing in person is actually really good for your mental health. So we hope to see you. We hope to see you there, and feel free to have some of your friends come too, even if they couldn't make it today. Because we all know there's no health without mental health. Thank you. And now I'll go to my